Welcome back to the endoscopic nasal surgery episodes. The case today is a case for bilateral frontal sinusitis, which has been complicated with a puffy puff tumor, also ended to get a sinus fistula through the skin. So we decided to drain the frontal sinus bilaterally using the navigation system. So after setting the navigation system, as you can see, we are exploring the nasal cavity, a small concabulosa of the right middle turbinate, which has been crushed down. Using the seeker to identify the maxillary sinus ostium. So it will be the first step to do unsinectomy. A full unsinectomy is necessary to reach the frontal sinus. Now is to register our seeker, sinus seeker, ostium seeker to the system, so we can localize where is the seeker end is. So once it's connected, we're gonna register it. Now we can say that the seeker can identify where you are. So this is the onset process and the maxillary sinus. So what I'm trying to do is just insert the seeker inside the infundibulum. Later, back biter to widen the maxillary sinus ostium. And again with the seeker to go through the infundibulum, reflect the onset process. So using either the microdebrider or the through cut to remove the onset process. After you remove the onset process using the through cutting, following this, just puts the you can see the probe inside the frontal recess, and you can see it's passing inside the frontal recess and the frontal sinus, and also you can see the pus comes out once we have removed the upper part of the onset process and widen the frontal recess. Again, you can see that we're using the probe inside the frontal sinus. The pus came out once we widen the ostium. So because this side was the easy side, it didn't take much time. The other side, which is the side that has the fistula has been developed, you can see that there is an ossification there. So it takes a bit of a time. We have to drill a lot, to be honest, to get to the frontal recess. But in this case, you can see this is the frontal recess, easily accessed. Just a little bit of a widening and removal of the tissue surrounding it, we can get easily to the frontal sinus. Myself, I like to remove a little bit of the mucosa and the bone in the from the axilla of the middle turbinate, not to make it flary, but this helps a lot for the drainage. This is the bulla, so it's bulla insect technique. Once we widening it, you can see we've registered the curved suction, and the curved suction is inside the front recess easily there. We couldn't push it down, as you can see there is a a kind of a thick bone for the ridge of the frontal. So it need to be drained. So anyway, we find that the as the passage has been widen enough to pass down from the frontal sinus, so no need to widen that or to drill the bones. Again, just some patties inside to decongest, to have a better look later on. So we went to the other side. Now we are in the left hand side. See, we are localizing the onset process. Again, the registration with the probe. Okay, so just to make sure this is the onset process. Yes, it's the onset process, and it's a bit pushed back. Same technique again. Identify the middle meatus. Opening of the maxillary sinus, so we can easily remove the onset process. Back bites, 1 and 2 bites, so that can help us to easily access the infundibulum and removal of the onset process. Yeah. So flicked again, and then through cuts or the microdebrider. Anyway, both of them could be used. Cleaning the tip of the through cutting, getting in the plexuly to remove the upper part of the onset process. And again, suction cleaning. All of this need to be removed. Just behind it will be the design, which is sometimes you need to remove it to access the frontal recess. Just using the tray to remove the upper part of the onset, reaching the design. So just make sure, yes. So the frontal recess will be just behind that design. And it's more posterior than we thought here. So all of this anterior bed is safe. As you can see on that side, there is a bony thickening obstructing the front recess. This is from the chronic infection, so it's a chronic osteitis, which is the area that I'm pointing on. You can see it on the navigator. I went to the other side just to explore it after decongestion. You can see the frontal recess is nicely open, and even you can see the drainage of the frontal sinus. And this is mainly on the right side. And this is the front recess, And you can see the frontal sinus opening. Just to show you where we are, the frontal recess in the frontal sinus, and it seems to be that we already passed a small frontal sinus cell. Again, a patty inside the frontal recess. We just decided to go to the other side just to make sure that we have put a nice decongestant on that the right side. So back again to the right side. So you can see I've removed a little bit of the bone of the axilla and the tissue around it, so we can open the axis. So what you can see is just the against eye has been opened. This is the area that I've just put the probe in, which is the frontal recess. You can see it's obstructed with a thick bony tissue in front. So all of the bone from the against eye to the point that you have seen need to be removed up. This is because the thickening is mainly in the frontal recess. And also we need to remove the frontal peak. In this case, not like the other case that we don't need it. Try to remove the bone with the through cutting. Seem to be not really work much. So the next step is using the drill. So I've used the frontal sinus drill, which I've registered as well to the navigator to see where we are. So this is the area, as you can see, that has been colored yellow, which is the area of the frontal recess area, and the thick bone is there. So in front of us, or just above us, will be the frontal peak. This drill is not the best drill to drill the thick bone, so it takes us a bit of time to drill it up. And again, to see where's the pathway, all of this thick bone need to be removed. Usually just what you need is just to uncap it. If this is just simple non-recurrent chronic sinusitis, or even a chronic sinusitis with no osteitis. So the bulla is still intact. What I'm trying to reach and find is just to make sure that we're not reaching or getting to the area of the anterior sigmoidal artery, which is a bit difficult on the scans to identify in this case particularly. Other cases more easier. As you can see, the floor of the orbit has been also eroded with the chronic infections. You can see the white thick bone there. All of this thick bone need to be removed to get through the area of the frontal recess. So this is, we are trying to break this sept in this area. Yeah. Now just managed to put a small patty through the frontal recess passage, but not to just have it open the frontal recess. So we need to remove all of this area to start to have a draft in that draft type 1, and then type B 2A, and then 2B. So just breaking through to get to the area. To be honest, with this bleeding without the navigator, it is very, very difficult to know where you are, and also to localize the specific area that you need to remove. So I use the probe, identify and remove the bone. But now just the frontal recess started to to show up, but still, as you can see from the scans, and I will show you, there is also a large interfrontal interfrontal sinus cell as well, so we need to remove it. So this is reaching the skull base in that area, so we need to drill more anteriorly again. So this is the frontal septum, frontal recess, and then yes, so there's a bone there that need to be removed, which is this is the interfrontal cell. Yes, so I've opened the cell now, but still not inside the frontal sinus. So the cell has been removed, opened, and you'll be surprised that there is like two flow later on. So this is the cell that's obstructing the frontal flow, and I'm using only the 0 degree angle scopes, so not the 30 degree. Despite this, you can see, yeah. So once we get in, the next step is to identify the passage inside the frontal sinus and also the cell, so to open them. Still the frontal recess almost open, but still narrow. We need to drain more bone. I know all of the superior to us or above us is the frontal peak, and it's very thick with the osteitis area. In the back you can see the nice loopy skull base, so just be aware of that. Okay, we're now above the bulla, so what's behind us, it just will be the skull base. Yeah, drilling the peak again. Yeah, you can see it here in the navigator, especially in the sagittal cuts. So now what you can see, there is like a septum and there is two passages there. So one is them is for the frontal sinus, and one of them for the frontal cell. Again, drilling more in the beak. Yeah. And now what we need to do is to go to be more lateral than medial, because you can see in this patient, the skull base is very, very shallow. If he goes, if you would like to classify it according to the Harris classification, it would be almost type 1. Again, thick bone there, you can see. So in the back, you'd be surprised that the patty is like inside the frontal passage, and what I'm drilling the thick bone in, or removing now, the thick bone that I'm removed by the curate, is mainly for the frontal interfrontal cell, and actually this is his main issue, or the main problem, and that's lead to the frontal sinus fistula. Just widening the axis again. The next, yes, and just the next question, whether we need to get down the partition or we don't need to do this. So I decided not to remove the partition between the intracell and the frontal sinus. So you can see now, yeah, I'm inside now the frontal sinus and its flow. And the cell will be more higher. Now, if I've drilled more, you can see this is the obvious skull base there, which is the bulgy in front of you there. Removing again from the bone, yeah. Take one here. See how much is this bone are. So what I'm trying to do now is just do some trans-elimination through the frontal sinus. And actually, as I said, this is eliminated inside this cell more than the frontal sinus itself. Okay. If we have the frontal sinus probe, will help us much, but or light cable probe, but we don't have it. So we have to do the traditional way. Drilling more, just mainly anteriorly at the peak to remove all of the partitions. This area is a bit scary because we will be more towards the skull base and the area of the olfactory nerve. So again, drilling to the beak, which should be superiorly there. So despite the video is 30 minutes, actually the operation took around 2 hours. So what I'm doing now, just through the fistula, I've tried to cannulate and flush the water inside. And yeah, I'm putting the probe inside just to see where we are. So this is through the navigator, so the probe of the navigator from inside to check where we are. So it will be inside and outside. Yeah, so this is, I'm reaching the skull base. Anteriorly, you can see this is the cell. So, and I'm going more lateral. So it means that what's above me now is just a soft tissue. So I need to remove those soft tissue. So I've managed to remove the thick bone. Yeah. So in the next step, we'll be trying to remove those soft tissue. Yeah. And you can see a little bit of a pus come out once I push the probe in. Yeah, I'm going more lateral and touching the lateral. You can see it there with in the coronal cuts. Okay, yeah. So this needs to be removed. All of this is just a granulation tissue. Moved out. I took it and sent it to the histopathology and as well as to the microbiology. So all of this granulation tissue again. Just this, you can see this flushing is coming from above, not from inside the nose. So we put a trocar and a cannula inside the fistula and just wash. So that means the water is coming out up from the frontal sinus, which is really good. You can see it's the residual water coming. So it's just a granulation tissue. And this is the partition between the intracell and the frontal sinus. So what will be in front of us is more thick bone from the beak. So whether we need to remove it or not will be the next step. Yeah. again, just see some air and fluid coming outside. Yeah, just again, flushing again, just to have a better look. And I decided to drill more from the peak, just to widen the frontal ostium. I still can use the 30-degree to get a better viewing, but so for me, just this will be enough. I don't like to work with the 30-degree because it doesn't give you an accuracy where you are, especially if anything in front of you could be above you, and what's below you, it should be in front of you. So can make a bit of a risk. You can explore the sinus with it, but working with it, it's a bit risky unless that you can see. So if you can't see, you have to work around, and you can see what we have removed now. And this cavity is like the agonizai, the frontal recess in front of you. I decided to get the small curved suction, because I know that what's behind me is a partition, not the skull base. So I tried to widen it a little bit up to make sure that the frontal sinus ostium is more widened, as you can see. So this pulsation happened because if you can see the coronal cuts, the patient have a little bit of a roof of the orbit has been like eroded with his infection. It's at the puffy puffy tumor. So this was the like a secondary complication from that. So then what I decided to do is just to ask to get some drainage tube, so we can insert it inside the frontal recess to prevent the secretration and the obstruction. So I've done it on both sides, just to make sure that this will not happen. You can leave this drainage for 10 days and remove it later. You can also suture it down to the skin, not inside the nose, just to make sure that it has been fixed. Small spongy stands or absorbable nasal pack can be very helpful. You can see it's just pushing it as much as I can to reach the lateral wall of the frontal sinus, and then suture it.